Wishing everyone a very happy new year. I'll be starting today with my presentation. I'll be speaking for the motion on the topic tips in the management of refractory variceal bleed. Portal hypertensive bleeding uh, has an important prognostic marker in the lifetime history of a patient with cirrhosis and carries a considerable short-term mortality. It is basically determined by the degree of the hepatic dysfunction, and the two which form the basis of majority of the trials are the failure to control bleed and the bleed related mortality. Failure to control bleed, that is the treatment failure or death within 5 days, or bleed related mortality is defined within 6 weeks. The vasoactive drug, prophylactic antibiotics, restrictive blood transfusion policies, early endoscopies, they are the mainstay for the management of bleeding episode. It is an important event in the life of cirrhotics, impacts the long-term prognosis, increased risk of developing another variceal bleed and mortality. It marks the transition from a stage of compensated cirrhosis with clinically significant portal hypertension, which carries a 5-year mortality of 10%, to portal hypertensive bleeding, which carries a 5-year mortality of 20%. Previously decompensated patient who have other decompensation apart from bleed, this can mark as a second decompensation event, and the 5-year mortality increases to 88%. So how to define refractory bleed? This can be defined as failure to control bleeding, that is acute variceal bleeding less than 5 death, or need to modify treatment due to one of the fresh criteria. Fresh bleeding in the form of hematemesis or nasogastric aspiration of more than 100 ml of blood after 2 hours of starting medical treatment or after endoscopic intervention. Development of hypovolemic shock, decrease in hemoglobin of more than 3 grams, or decrease in hematocrit of 9% during any period of 24 hours if no blood transfusion is done. And the failure of secondary prophylaxis is one episode of rebleeding after 5 days from a portal hypertensive source which is clinically significant. Rebleeding in form of recurrent melena or hematemesis is clinically significant if one of the following is present, that is either requires hospital admission, needs blood transfusion, decrease in HB of more than 3, or death in the period of 6 weeks. So the standard algorithm follows the use of early vasoactive medication, prophylactic antibiotics, and therapeutic endoscopic procedure. Despite that, there is a 10 to 20% rate of treatment failure and mortality. TIPS has shown as a clinical efficacy as salvage therapy or a preemptive as a secondary prophylaxis for cirrhotic patients who have failed endoscopic or pharmacological therapy. However, the mortality in this high group can reach up to 50%. In Bavanu 6 recommendation and current UK guidelines recommend early preemptive insertion of TIPS in child C with a score of 10 to 13, or in child B with active bleeding. So how did TIPS came into the picture early on? This basically was a paper published in Gastroenterology 99, which basically shows patient who have HPBG more than 20. They were named as poor evolution. That is, the patient who have poor evolution, that is HPBG more than 20. The failure to control bleed, or there is a high risk of failure to control bleed or early variceal bleeding. The 1-year mortality in these patients reaches up to 64% as compared to the patient who have less than HPG less than 20 of 20%. And a majority of the patient who had poor evolution happened in patients which have HPG more than 20. So coming on to the role of TIPS in a patient with cirrhosis and refractory variceal bleed. The unique characteristic of TIPS is basically it causes it has relatively low invasive even in patients who are vulnerable, and cause profound amelioration of this portal sinusoidal pressure. However, it decreases portal vein velocity and decreases intrahepatic resistance. This basically shows the changes which are seen with TIPS. And initially there is increased portal pressure which is reduced with there is reduction in the portal pressure, there is a decrease in the hepatic resistance. However, there is an increase in the cardiac output and effective blood volume, and increase in renal perfusion, which are noted with the TIPS. So coming on to the TIPS which have been defined for bleeding, this can be defined as pre-primary or primary prophylaxis. Then there is preemptive TIPS, and there is secondary prophylaxis after the bleeding from the esophageal varices. pre-primary and primary prophylaxis for esophageal varices, there is comparatively low risk of acute variceal bleed in non-bleeder, and the risk outweighs the benefit, so it is not indicated. Most of the studies are present on preemptive tips, which is defined as early or usually within 72 hours of admission. It is the preventive insertion of the tips, which is indicated in patients who have high risk of uncontrolled bleeding or bleed-related mortality. It is highly effective in controlling acute variceal bleed and preventing the episodes of rebleeding by causing the profound reduction in portal pressure and hence subsequently preventing the organ failure or the development of ACLF and reducing the risk of bleed-related mortality. So, who needs tips? The importance here is to identify the high-risk population. HUPG more than equal to 20 have poor bleeding control and higher risk of failure to control bleed, which can reach up to 5-fold, and they have higher risk of in-house mortality, bleed-related mortality, and higher risk of 1-year mortality. These are the various RCTs which has been done on preemptive tips. First was by Monicillo et al., which included 134 patients, of which 52 patients were randomized into standard arm and in tips. The main inclusion criteria was HUPG more than equal to 20, and this basically showed the failure to control bleeding decrease favoring tips. There's a decrease in the in-house mortality, bleed mortality, and a 1-year mortality, which was noted with tips. Similarly, the other study was by Garcia, Pagan and all, which included 63 patients and randomized 1:1, and the inclusion criteria was child B with active bleeding or child C with the child book score of 10 to 13. They basically showed there is a degree, the study favored tips in controlling the bleeding, reducing the 1-year mortality, favoring the tips, and there was a decreased trend which was noted in the development of ascites or worsening of ascites, which was noted in the patient who underwent tips. The other study was from China, which was had the inclusion criteria of child B with active bleeding and child C with 10 to 13 of child book score. And this study also showed a similar result. There was a decreased risk of rebleeding or failure to control bleed with tips, and 1-year mortality was higher in the standard arm as compared to tips, and the worsening or development of de novo ascites was more in the standard arm as compared to the patient who underwent tips. These are the studies which are have been described. This was a study which was by Garcia, Pagan and all, and this was the first RCT which showed which was done in as a preemptive tips. It was a multi-center style and included 63 patients. Inclusion criteria was child C with score of 10 to 13, child B with active bleeding, randomized standard arm which had band ligation plus sclerotherapy plus vasoactive drug, and tips which is covered stent and which was placed within 72 hours. And 1-year survival was 86% for the tips arm as compared to 61% for standard of care arm, which was significant. This was another study which was published by the same group. This was published in Hepatology 19, which was a multi-center international observational study, and of which 671 patients from 34 center was taken. 605 patients underwent drug plus endoscopy, and 66 had preemptive tips. On propensity score matching, in preemptive tips, there was a low mortality in the child C as compared to the drug plus endoscopy arm. The mortality rate, however, in child B was low, and tips did not improve it. There was a difference in mortality in the child C, however, in child B it was comparable as compared to the standard of care arm. This was a study which was from China, which included patient 1425 patients with cirrhosis and acute variceal bleed, of which 206 patients underwent early tips, and absolute risk reduction of mortality was more pronounced in high risk group. Absolute reduction at 6 weeks was up to -32% in patient who had MELD score of 19 and -23% in child C cirrhotics. This study basically showed as the child score and the MELD increase up to 30, there was a survival benefit which was noted in the TIPS arm as compared to the standard of care arm. Similarly, with a patient who had creatinine of more than 1 at the baseline and presented with acute variceal bleed, they had mortality benefit by placing early TIPS. So this study basically showed that early TIPS improve survival in patients with MELD more than equal to 19 or child C cirrhotics. TIPS is not recommended with child A or MELD less than 11, MELD 12 to 18 or child B. Further studies addressing the optimal selection criteria for early TIPS should be done. This is the only negative study in the setting of the preemptive TIPS, which included 58 patients with child B and a child C cirrhotic with 10:13. This was published from UK. This basically showed that there was a comparable 1-year survival between the patient who underwent TIPS with standard of care arm in TIPS which was done as a preemptive TIPS. However, in this study, 29 patients were randomized to early TIPS. 6 patients did not receive TIPS, and 10 patients received the TIPS outside the 72-hour window. So, coming on to the TIPS in ACLF, this was a study by Trebikow et al., which basically showed there is high risk of rebleeding in patients who had ACLF and hence increased risk of mortality. And placing a TIPS in patient who had ACLF, this was as defined as per Cliff. 66 patients were included, of which 44 underwent preemptive TIPS. This basically showed there was a significant risk of reduction in the risk of rebleeding and reduction in the mortality at 6 weeks and 1 year in patients who underwent preemptive TIPS and ACLF. This was a systemic review which basically compared 5 studies with 1754 participants, and this showed the early TIPS had a significant improvement in prevention of treatment failure, 6 weeks mortality, reducing 6 weeks and 1 year mortality, development of new or worsening of ascites, and there was no deterioration in the risk of encephalopathy. This basically shows the same. So there are multiple RCTs that have been done on preemptive TIPS. The key highlights from them: preemptive TIPS basically improve survival in high-risk patient. Careful patient selection is important, which puts forward a strong rationale for its application in clinical practice. The preemptive studies majority have shown survival benefit in patients who have child C cirrhosis or child B with active bleeding or MELD more than 19 up to 30. There is no increased risk of portosystemic encephalopathy, and there is a decrease in the incidence or development of de novo ascites or worsening of the ascites. Coming on to salvage TIPS, which is basically when there is failure to control the endoscopic bleed. However, candidates for rescue therapies or salvage TIP are less as compared to the prior time because of the availability of the Denisilla stent and use of the preemptive TIPS. Variceal bleed who underwent a salvage TIP died within 6 weeks. This basically showed the comparison between the covered versus non-covered and the use before and after of the preemptive TIPS. The estimate rate of death within 6 weeks is comparable, and 1 year is comparable between the two arms. Similarly, the risk of rebleeding and death from bleeding is comparable between both the arms. This was another study which was done on the rescue or the salvage TIPS, which included 144 patients, and 3 logistic regression multivariate models were used to individualize the prognostic factor for the 6 weeks and the 12 months mortality. The mean age of the patient was 51, MELD score was 18, and majority of the patients were child B or C cirrhotics. This study showed 6 weeks mortality and 12 months mortality of 36 and 42% in patients who underwent salvage TIPS or rescue TIPS. The predictors of rebleeding or mortality among the patients who underwent salvage TIPS were low MELD score, a child PUC, and no ICU stay prior to TIPS had improved 6-week survival. The futility is for patient who had a child PUC score of 14-15. platelet is in 75, bilirubin more than 3, carries predicted the mortality up to the CTP score of 10, and up to 10 to 15 the low platelet and high bilirubin was had no mortality in predicting the mortality. MELD score was important in predicting the 6 weeks mortality, and 1 year mortality was predicted by the child score at the baseline. I'll touch in brief about the secondary prophylaxis, which is after bleeding from the esophageal varices. There are multiple, there are 4 RCTs which have been done. First by the Escarol et al., in which patient underwent TIPS after the bleeding was controlled with the vasoactive drug and endoscopy, preferably band ligation, and it was done in child BC cirrhotics. However, in secondary prophylaxis, there was there's reduced risk of rebleeding, which was noted in all the studies, and decreased worsening of the ascites. However, the quality of life and the mortality benefit was not seen in any of the studies. Another study was by Saur et al., which included 85 patients. The patient underwent TIPS within 3 days after the control of acute variceal bleed with vasoactive drugs. And similarly, the failure to control bleed in this study was not significant at 5 years. Failure to control bleeding at 5 years was comparable between the both arms, and mortality was also comparable between both arms. The other study was by Holster et al., which randomized a patient in 72 patients, and the TIPS was done at a median of 4 days after the control of first or the second variceal bleed with band ligation. Rebleeding was favoring the TIPS, however the mortality benefit was not noted. Similarly, Sorbach et al., 185 patients were randomized within 21 days or after 21 days in almost 56 to 44% of the patient in acute variceal bleed, which was controlled by the vasoactive drugs and endoscopy. Rebleeding rate favored TIPS, however the mortality and the quality of life was similar between the two groups. So the key highlights of the secondary prophylaxis for TIPS: patient in TIPS arm had lower rate of rebleeding. However, higher incidence of portosystemic encephalopathy was noted when TIPS was used as a secondary prophylaxis. Survival was not, and the quality of life was not improved by TIPS in any of the studies. So we need to identify the patient who will be the candidates for secondary prophylaxis. So which stent to be used, whether 10 mm stent to be used or 8 mm stent to be used. So currently there is no recommendation for the preferred diameters of the stent. This was a study in which 64 and 63 patients were allocated to 8 mm and 10 mm. And the follow-up was for 27 months. The overall dysfunction rate was comparable between the two arms. 2-year bleeding rate was also comparable between the two arms, and overall transplant-free survival was also comparable between the two arms. However, a risk reduction in the spontaneous overt HE incidence was noted, which reduced up to half of the risk with 10 mm stent with the 8 mm stent. Smaller diameter stent have been associated with increased survival. This was a study which was published in CGS 19, which included 185 patients and 107 patients for refractory ascites and 78 with refractory variceal bleed. And most of the patients who had bleed underwent 8 mm stent. 8 mm stent had longer survival as compared to the 10 mm stent, and the decreased incidence of encephalopathy was noted with the 8 mm stent. However, there is a lesser reduction of the pressure gradient, and the 8 mm stent required significantly more revisions. This basically shows the survival benefit with the 8 mm as compared to the 10 mm stent. So, is the presence of encephalopathy at the baseline a contraindication to TIPS in high-risk patient who presents with cirrhosis or variceal bleeding? This was a RCT which was recently published in 22, which included 2,138 patients from 34 centers, of which 671 had high-risk tips, that is, they had more than or equal to grade 2 encephalopathy at the baseline, of which 66 underwent tips and 605 underwent endoscopy plus drug treatment. HE was significantly more in high-risk population. How in patient who underwent preemptive tips had lower 1-year mortality as compared to the patient who had HE with endoscopy and drug in high-risk population. The incidence of encephalopathy post-tip placement was not different between the patient who underwent TIPS preemptive and or underwent endoscopy plus drug. And this study basically showed the independent factor of death was presence of encephalopathy at the admission, age more than 56, presence of shock at admission, MELD score more than 15, use of endoscopy plus drug treatment for the management of bleed, and patient who had encephalopathy at the baseline. This was study which was done in management of the variceal bleed as a combined therapy, which was like a single center retrospective study of 40 patients who had combination of TIPS plus variceal obliteration of gastric varices versus TIPS alone. Combination therapy had higher risk of variceal eradication and lower rate of gastric variceal bleeding, with no worsening of ascites, encephalopathy, esophageal variceal bleed. So the limitations of early TIPS are age more than 75, pregnancy, hepatocellular carcinoma outside Milan, creatinine of more than 3, Child-Pugh score of 13, prior and non-selective beta blocker plus endoscopic treatment to prevent rebleeding, prior history of TIPS, bleeding from isolated or gastric or ectopic varices, total portal vein thrombosis, or in presence of heart failure. And patient in which TIPS will be futile will be Child-Pugh more than equal to 14, MELD of more than 30, lactate of 12 at the baseline, and decision to perform TIPS in these patients should be on case-to-case basis. Apart from HUPG, which has been defined more than 20 as an indication for early TIPS, need to define the high-risk population for early TIPS based on the these are the studies which have been done for preemptive TIPS. Basically, they included high-risk population, that is child B and C. Etiology can be used for the determination of the high-risk population and the pre-TIPS portal pressure gradient. Coming on to ILBS data, this was provided by Dr. Amar, and the paper has been recently accepted in Hepatology International. They basically showed that TIPS within 8 hours improve survival in acute variceal bleed. They included cirrhotic with variceal bleeding. Number was 121, and rescue TIPS was done within 24 hours in 66 patient. And Denisela was placed in 55 patient, and Denisela patient had a higher 6 weeks mortality and 1 year mortality as compared to the TIPS group. And the comparison was made between the patient who had underwent TIPS less than 8 hours and defined as very early TIPS and early TIPS, which was between 8 to 24 hours. Very early TIPS number was 31, early was 35, and majority of the patient was CTPC with a MELD score of 19 and 25 in very early and early respectively. Very early compared to TIPS compared to early TIPS had a lower 6 weeks mortality of and lower 1 year mortality and comparable rebleed rate. The predictor of mortality in this study was active bleeding present at the endoscopy, presence of AKI at the baseline, MELD score of more than 24, and mean arterial pressure of less than 64 mmHg at the baseline. There was another study which was done by Dr. Sushrut which compared TIPS versus Denisela, in which 623 patients were screened with bleed, of which 509 patients had acute variceal bleed, of which 157 patients, that is approximately 1/3, had a rebleeding or failure to control bleed. of which 41 patients were randomized, 21 in SEMS Denisela arm, 20 in TIPS arm, with a mean CTP of 9, MELD of 18, and HVPG of 19 mm, which were comparable at the baseline. 6-week mortality was lower in the TIPS group, that is 10% versus 50% in the TIPS group, and 3 months mortality was also higher in the SEMS group. New onset AKI was lesser in the TIPS arm, however was not significant. Incidence of sepsis was more in the SEMS arm, and the mean time to sepsis was also higher in the TIPS arm as compared to the SEMS arm. So coming on to the algorithm, if the patient presents with acute variceal bleed, the initial task is basically stabilization, protecting his ear by restrictive transfusion, covering him with antibiotics and vasoactive drugs, do an upper GI endoscopy, band ligation. If the bleeding is controlled, patient is low risk. Secondary prophylaxis in high risk population, preemptive tips should be offered. If the patient is having persistent bleed, SEMS should be placed, and the patient should be offered rescue tips or salvage tips with BRTO. Similarly, for gastric variceal bleed, if it is controlled, secondary prophylaxis should be added, balloon tamponade if it is not controlled, followed by BRT or rescue tips. So to conclude, TIPS facilitates the management of endoscopic treatment which are difficult or have been failed to control with endoscopic therapy or drug therapies. It's an excellent treatment for acute uncontrolled esophageal variceal bleed, mostly in patients with high HVPG. New biomarkers such as ARC score, Cliff score, or MELD score, or systemic inflammation biomarkers should be determined to define the utility or the indication for TIPS, and they can be tend towards biodegradable TIPS, which degrades itself after 2 to 3 years, so to prevent the secondary complication of the TIPS such as encephalopathy or pulmonary hypertension.